you divided into four sessions, right? So in today's session, the important topics that we are going to cover are obviously the mammary gland or the breast, then basically the region of the axilla, and not just the boundaries of axilla, but also the contents, meaning the axillary artery, vein, and various muscles, and also about the boundaries as well, right? A brief about the brachial plexus also we'll try to discuss. So this is what we are going to do in today's session. Okay, so if you have any queries, guys, from the previous session, also go and watch. And if there are any queries regarding any topic, do reach out to us in the comment box at least so that we can answer there appropriately. So important, let's see about the core features of Oracle as well. It has live classes, as you can see already. It will also be having the recorded session. So if you are unable for live, you can go to the recorded part, notes plus MCQs. So I guess everything is there for your preparation. Okay. Next thing, subscription plans are there, right from basic, which is for 3 months duration, to mentorship, which has 12 months. In between, we have a standard plan also, which is of a duration of 6 months. It goes from 15K to it goes around 50K, which is for the whole 1 year subscription. Along with the all the notes that we have seen that we are having the recorded live and notes and MCQs. Here also we are going to have them live dot clarification, personalized guidance also going to be provided to you guys, and quick revision examination module will also be provided to you. So these are the features which you will find in basic to mentorship program. Depending on your requirement, choose wisely. And also book a slot for personalized counseling session. We have the special feature, and I'm sure you guys are going to like it. So coming back to the topic now. So topic for today's discussion, as I already discussed, that we are going to have basically the pectoral region as well as the axillary region. Okay, pectoral region is the front of chest. The main content is the mammary gland or the breast. And axillary region, as you'll see, that axillary region is the space between the upper limb and the whole body, and the contents of it. Okay, so let's move on to this to the notes, and I will show you some images as well as MCQs also after it. Okay, fair enough. So let's start. So the first topic over here for the session is the breast. The breast, as we all know, is also known as the mammary gland. It is also known as what? It is also known as mammary gland. The main function of breast is to provide nutrition to the newborn. And as we all know that the mammals, we all are mammals. Mammals are named according to the mammary gland. So any species who has mammary gland is known as mammals. Simple as that. Let's see. Coming to the anatomy part. So the question might come as right about the breast or mammary gland, its location, its extent, its blood supply, of all of these things. Now, first of all, why is this topic so important? It's an important part of the body, fine. But we should know that before going to the topic, understand the importance that the carcinoma or the breast cancers, they are the most common cancers for women worldwide, not just in India, but worldwide. The most common cancers affecting women, affecting the female population, is the breast cancer. So you can understand how important it is to understand the anatomy. Because unless and until you know the anatomy, only then you will be able to treat it, both chemotherapy or surgically likewise. So let's see. So right about breast. So breast, understand, it is basically a modified sweat gland present in the superficial fascia of the pectoral region. So it is present where? It is present in the superficial fascia, a very important point. Why? Because once you are making an incision through the skin, the next tissue which you get is the superficial fascia, that is the breast in the pectoral region. And it is a modified sweat gland. And as we know, the basis of histology, that a gland will have what? A gland will have obviously the acini, which are the cells which are secreting the substance, whatever here the milk. And also it will have the ducts by which those secretions are there's an exocrine function, so secretions are transmitted out. So basic structure of the sweat gland or any gland is having a acini in the ducts. This is what you're going to see in the breast as well. So it's a sweat gland, it's a modified sweat gland found in the superficial fascia of the pectoral region. Point number one. This is how you're going to start. Location, we all know, we can't just write it is present in the front of chest, but you have to give some details over here. Details will be that it is present in the front of chest, fine, but it has a small extension which is known as axillary tail of Spence that will reach the axilla. Now here in this image, you are seeing this over here. This is the breast region, right? This is the breast region. But what you see over here is its extension that is going into the axilla. This one, that is known as axillary tail of Spence. Fair enough. Now you might think that what is the use of it? Remember the clinical use. I will be telling in between. The clinical use of the small axillary tail of Spence is that it forms a differential diagnosis sometimes of an enlarged axillary lymph nodes. As a doctor, we might be confused of a swelling in the axilla and may just outrightly say it is a lymph node enlargement, but at times it could be simply enlargement of the normal breast tissue. So remember that. So it reaches a part of the breast reaches the axilla through that is known as axillary tail of Spence. In addition, that was actually a recent question in the recent INI-CT and EPG exams, that it passes through which opening? The opening is known as foramen of Lange. So remember that name also. Now these things you can highlight in the exams also, right? Now coming to the shape, we all know it's a hemispherical bulge. Now this is the extent that is very, very important. Now that's a natural extent, or by development that is the extent. But let me tell you, I will tell you later on what actually is the difference. When you talk of extent, you have to talk of two extents. One is the vertical extent and one is the horizontal extent. Vertically, it goes from where to where, and horizontally, it goes from where to where. Vertically, remember, it is going from second to sixth rib. And as we have discussed that how to count the ribs, the second rib is how is it counted? You have to just look for the sternal angle. In the bones we are discussing, in the general anatomy, is sternal angle. The sternal angle is a joint between the manubrium and the sternum, and the body of the sternum. At the sternal angle, we have the second rib. So vertically, it is going from second to sixth rib, and horizontally, it goes from lateral border of the sternum to the mid axillary plane. That is a normal developmental. But remember, practical purposes. Okay, for practical purposes, remember that this is just a normal extent. It can go way beyond it. So on a practical aspect, if there is a female who's coming to with a CA breast, carcinoma breast, and you have to do a surgery, for practical purposes, the extent is much wider than this. Extent is much wider. It is much bigger or much wider than this. This is what you have to just keep in mind. Okay, so you know second to sixth rib and parasternal to the mid-axillary plane is a normal, but for practical purposes, it can go beyond depending on the age and the disease. Second thing, relations. Now, for relations, you have to need to understand one thing, that for relations, that the breast mammary gland is present in the superficial fascia. Superficial fascia, this is what you need not forget at all. So if you know the basics of anatomy, that we have the skin outside, right? Then we have the superficial fascia, then we have the deep fascia, and then we have the muscles, right or not? And muscles are deeply attached to the bones, and in between the muscles and the deep fascia, we have various vessels and all. Now, where is the breast tissue? Remember, breast tissue is present over here. The breast tissue is present over here. So you know the superficial relations, and you should knowing the deep relations. Simple as that. So superficially, what will be there? Superficially, obviously, there will be skin, sweat glands, sebaceous glands, all these structures will be lying superficially. Now, what will be lying deep to the breast? Deep to the breast will be the deep fascia. Now, here in this case, in case of breast, the deep fascia is known as pectoral fascia. Deep fascia is known as pectoral fascia. The reason is very simple, because it is covering the pectoralis major muscle. It is covering the pectoralis major muscle. So that is the main structure lying deep to it, right? So the main structure lying deep to it is the pectoral muscle. Just let me show you over here. This yellow color structure which you are seeing over here, this yellowish color structure with the axillary tail, this whole is the breast tissue. This whole is shown as I'm outlining this black dots over here. This whole is the breast tissue. Now, can you see this muscle, this red color muscle? Which muscle is this? This is obviously the pectoralis major muscle. This is the pectoralis major muscle. So it obviously forms a deep relation. It obviously forms a deep relation covered by the fascia and all. So that is the basic relations of the breast tissue, which we can say is the superficial and the deep relations. Here we can see pectoral fascia, deep fascia, as I already told. Now, deep relations, you have one major muscle is pectoralis major muscle. That is the main content, right? But other relations, we can say going slightly posteriorly, we have the serratus anterior muscle. Because remember, from where is this muscle coming? This muscle is coming from the scapula. Scapula is a bone where in the posterior part of the thorax. And inferiorly, you will have a muscle known as the external oblique. Why? Because this muscle is going to the abdominal wall. It's going to the abdominal wall. Okay, and remember that pectoralis major muscle has the origin from the external oblique aponeurosis as well. So major relation, deep relation is P major, pectoralis major. But on the posteriorly, or you can say lateral and posterior, we have the serratus anterior, posterior, and slightly lateral. Lateral means on the outside. And as you go down inferior, you have a deep relation of external oblique. Why? Because it's muscle of the abdominal wall. See, in anatomy, we always have to understand a bit of why, not exactly details of why, but a bit of why. Okay, why it is there, something like that. That helps us in remembering. Now, coming to the structure of the breast, as we discussed in the beginning, what is the breast made up of? It is a modified sweat. What glands? Glands, as I told you, two things: has a acini and it will have a ducts, and between you have a stroma, right? These are the major contents. Now, in a non-lactating female, the female who has not given to birth, who is not lactating, the breast are not secreting the milk, they will obviously have more of fatty tissue, more of fatty tissue. And obviously, the female who is lactating, they will have more of acini, more of duct, right? And the stroma over here will be having some suspensory ligament. They will be having some suspensory ligaments over here. Now, why are they important? See, over here, let us use some common sense. Common sense is very important, guys. For learning anything, you need to have some amount of common sense. Let me show you one thing over here. See, suppose this is the chest wall. This is the chest wall, right? And here you have a breast tissue. Here you have a developing breast tissue, which is now developing more and more, having the nipple areola and the breast tissue. Now, with the effect of gravity, obviously this breast tissue will have some weight and it will be pulling down. That is a normal thing, right? Just to prevent the sagging of the breast. Now, just to prevent the sagging of the breast, understand first of all this point. What we have the ligaments going from the dermis of the skin to the deep fascia. This is in the stroma. These are specialized ligaments that goes from the dermis of the skin to the deep fascia. These are known as the suspensory ligaments, right? Why are they? They are to prevent sagging of the breast. Because with gravity, obviously, it will sag. Now, the question that could arise in your mind is, okay, sir, let the breast sag a bit. What's the big deal? The deal is this, that what is inside the breast? Inside the breast, you have the acinis, right? And you have the ducts. Here you can see all the lactiferous ducts over here. Okay, you have all the lactiferous ducts over here. Let us understand from this side. So if the gravity starts to pull the breast down, then these ducts which are on the upper quadrant of the breast, they will be pulled. They will be pulled more. And obviously the functioning of the gland will be hampered. Now, if the breast is unable or if the female is unable to lactate the child, then what's the use of this organ? Therefore, to prevent this, we have those suspensory ligaments. Remember, that is very important. You'll understand more. So structure of the breast, remember, you have to start just with the basic understanding of glands. With the glands, you know, it's the acinine ducts. And these ducts, where do they open? Also, remember, all the ducts over here, they will open into the nipples. The ducts will open into the nipples, from where the newborn, the infant, sucks the milk from the mother's nipples. So the ducts are opening onto the nipples. Nipples are, on the other hand, are covered by areola. I'll just show you that structure also. Let us discuss that also. See, these are the nipples over here, where the ducts are opening. Outside the nipples, you have an areola. So you have areola over here and you have a nipples over here, right? Nipples function, we know, okay, nipples having the duct. What is this areola doing? Areola is having basically sebaceous glands. Why? To lubricate the nipples all the time, so that the nipples are not dry and they don't crack when it needs the most, that is for lactation. Because during the time of lactation, the nipples become dry or cracked, and that function will also be lost. So it is mainly during the lactation time that the areola has specialized sebaceous glands known as glands of Montgomery. They are known as glands of Montgomery, and this is all you can highlight in your answers. So coming to structure again, it is basically glands having acini duct. Ducts are opening into the nipples, right? And surrounding there is stroma and fatty tissue. So in a non-lactating female whose acinis are not working, acini proportion is less, fatty tissue proportion is more. In a lactating female, the acini in the duct proportion will be more and the fatty tissue proportion will be less. And to support and to prevent the sagging of the breast, we have the suspensory ligaments. So breast don't sag normally. If they start to sag, the half of the breast will be non-functional. Clear? So this you have to understand. And one function of every nipple, areola, this is also needed over here. As in the notes we can see, skin has a nipple over here, conical projection at the level of fourth intercostal space. Right? Because in female, see, when the breast size increases, this nipple location corresponding to the intercostal space is not justified in all the females because the breast size may vary. Right? The stroma, as we discussed already, it has these suspensory ligaments. I'm just highlighting You also, guys, you have to highlight them in your exam. Suspensive ligaments of Cooper. Later on, I will tell you the clinical importance of it. And it is around 15 to 20 lobes having these lactiferous ducts and all. Right. So remember these basic points. Now coming to the arterial supply of the breast. Okay, it's a tissue in the superficial fascia. Now, just looking at the diagram, see anatomy, you will actually learn beautifully with the help of diagrams. Just look at the diagram over here. What you are going to see is you are seeing a group of arteries. You are seeing a group of arteries from the medial aspect. Can you see this artery going down? Which artery is this? Internal thoracic artery. This artery over here is known as the internal thoracic, also known as internal mammary artery. Internal mammary for the mammary gland. 1 point. Second group you are seeing on the lateral side, you can see this artery coming down. This huge artery. Which artery is this? This is lateral thoracic artery. So let me highlight this. Lateral thoracic, remember. Internal thoracic artery, remember. These two arteries do remember. Then as we know that the breast, what was the deep relation of breast? The deep relation of breast was pectoralis major muscle, then it has serratus anterior muscle, these muscles. Now, where are these muscles located? Over which bony structure? They are located over the ribs. And do we have any vessels running on the ribs? The answer is yes. Which vessels? Intercostal vessels. Very good. Intercostal means between the ribs. So you have a group of arteries which is running over the ribs. It will supply the breast also. So here you have this posterior intercostal arteries also. So this could also be a part of the arterial supply. So no need to cram, guys. Just understand where the artery is coming. For the branches, do please remember that lateral thoracic artery is a branch of axillary artery, which we will see more. Internal thoracic artery is a branch of subclavian artery. Let me write over here. It's a branch of subclavian artery. And these intercostal arteries, they come from different branches. The posterior ones mainly come as a direct branch of abdominal aorta. No, sorry, thoracic aorta, not abdomen, but the thoracic aorta. Let me just erase this. It is coming from the thoracic aorta. Okay. Let's just write th dot aorta over here. So remember these three major vessels. The main vessel over here is lateral thoracic artery, more than internal thoracic artery, more than intercostal arteries. If we talk of the main vessels, volume wise, right? A bit of sentences over here. Internal thoracic artery will supply this, axillary artery over here, and posterior intercostal through this. That's it. Now, as we have arteries, we have the venous drainage as well. Same. Okay, it is similar because you have a lateral thoracic vein, you have an internal thoracic vein, you have a posterior intercostal vein. Simple as that. So there's no much worry about the veins if you just remember about the arteries. So here you have the veins also, internal thoracic vein already written all over here. Just highlight or make in bold when you are writing in your exams. Nerve supply can come, and you know how to see it. It's very simple. Second to sixth intercostal nerves. If I ask you, if I say it is very simple, once you know the extent of the breast, it is very simple. Apply common sense. See, breast was itself, the vertical extent was from second to sixth rib. So which nerves are over there? They are second to sixth intercostal nerves. So they are going to supply the breast. Simple as that. Lymph nodes is very important. Lymph nodes very, very, very important. These lymph nodes are also referred as axillary group of lymph nodes. Okay. And in axillary group of lymph nodes, we have few categories. We have few categories like what? See, we have an anterior group, we have a posterior group, we have a lateral group. One thing. All these group of lymph nodes, they drain where? They drain into the central group of lymph nodes. Another thing. This central group of lymph nodes then goes where? It goes to the apical group of lymph nodes. So we have basically in axilla, draining the breast, we have these 5 group of lymph nodes. Right from anterior, posterior, lateral, they all go to the central group of lymph nodes, and from there it will go to the apical group of lymph nodes. From apical group of lymph nodes, then it will go to the supraclavicular group of lymph nodes. That is different thing. That is supraclavicular. First thing understand. And sir, how to remember which is which? See, the lymph nodes which are anteriorly located are known as anterior group of lymph nodes. Anteriorly means in the just at the lower border of the pectoralis major. The lymph nodes which are located posteriorly in the axilla, mainly subscapularis muscle, posterior group of lymph nodes. The lymph nodes which are coming from the upper limb known as lateral group of lymph nodes. Right? Lateral, we have the upper limb. Then all these 3 groups, they drain into central, they drain to apical group of lymph nodes. But now look at the diagram over here. Just look at the diagram over here, right? So you can see these green dots, these are all the lymph nodes. And do remember that in drainage of the breast, once you write this topic, 75% of the drainage, they go to the axillary lymph nodes. 75%. They go to axillary lymph nodes. Then you also see that 20%, around 20% of the drainage, they go to the internal mammary or internal thoracic lymph nodes. These lymph nodes. Internal mammary or remember internal thoracic lymph nodes. And 5% of the drainage that goes to the intercostal lymph nodes. Intercostal lymph nodes. At least have this idea. So if a question comes only for the lymph nodes, remember to write it in groups, to write it in percentages. Also, if you have to make a diagram somewhat like this or maybe some simpler, that would be good. So you have 5 group of lymph nodes in the axilla and you have this percentage wise distribution. Now adding to this knowledge over here, also do remember over here that here we have another grouping that is known as level of lymph nodes. So what we can write over here in axillary lymph nodes, one is this 5 group of lymph nodes, one is level of lymph nodes. Now this leveling will help you in clinical standpoint. For clinically, this leveling is very important. How? See how what happens is here you have 3 levels, level 1, then we have level 2 over here, and then we have level 3 over here. What actually happens is the key muscle or the key structure in the axilla is the muscle pectoralis minor. So remember one name at least, that the key muscle or the key structure in the axilla, in the whole axilla, the key structure is pectoralis minor muscle. Now what happens is all the lymph nodes which are lateral to this, see this is the pectoralis minor muscle. Let me just put a big black circle over here and write it is the pectoralis minor muscle. Now see what happens is that all the lymph nodes which are below and lateral to the P minor, all of these lymph nodes, they come under level 1. All. So it is easier on a clinical standpoint. Because in clinically, when you're opening up the axilla and you look for any lymph node, and obviously you might be confused that it is an anterior group or a posterior group. Okay. Level 1 is every lymph node, all the lymph nodes which are below and lateral to the P minor. Level 2 lymph nodes are around the P minor or just in front of P minor or just behind the P minor. Those are known as level 2 lymph nodes. And here one question normally comes is between the pectoralis minor and major, if you have any lymph nodes present between the pectoralis minor and major. So what actually happens is, let me tell you that also, what actually happens is deep you have the P minor muscle. Okay. Deep you have the P minor muscle. And covering it, you have the P major muscle. So if there is any lymph node which is between P minor and P major, that is known as, specially named as Rotter's lymph node. So remember that terminology. That is known as interpectoral between P minor and major. So that is level 2, that is around P minor. And level 1 will be all the lymph nodes which are above and medial to the P minor muscle. So this is subclavicular or basically the apical group. If we go into that scenario about how we have divided, then this will be actually the apical group of lymph nodes. This one will be the level 3 lymph nodes. Central will be around level 2. And so central will be around, say, level 2, apical is around level 3, and these anterior posterior, they come under level 1 lymph nodes from a clinical standpoint. Okay, so this lymph node grouping or lymph node division is very important in case of breast. So do remember this, right? Here we have in a tabular form. Okay, so here you have anterior, posterior, central, then internal, all those lymph nodes are given over here. And just additional, you have a cephalic nodes that also you can understand. Lymphatics draining the breast, again, the same thing that we have discussed. But majorly now, see this image you can make in case of a question which comes only for the lymphatic. Okay, to gain some extra marks. You can just simply draw a circle showing us the breast tissue or the mammary gland over here. And just major 75% of the drainage will go through the axillary nodes. Axillary, what was the last part of axillary? It was the apical group over here, right? Out of 5 parts. Then that goes to supraclavicular, and that will go to the thoracic duct on the left side. The rest 25% will go into the internal thoracic or the internal mammary. Now here is a clinically important. Why? The reason is we normally do what? We normally divide the breast into 4 quadrants. Suppose this is the nipple areola. We divide the breast into 4 quadrants. This being the left-sided breast, we will say superior lateral quadrant, superior medial quadrant, inferior medial, and inferior lateral quadrant. Do remember that the carcinoma, if you talk of just carcinoma, then maximum carcinoma will occur in the superior lateral quadrant. Maximum number of carcinoma. Okay, therefore, in maximum number of cases, the lymph node involved will be the axillary lymph node, because the superior lateral quadrant, it will basically drain into axillary lymph node. But if the carcinoma is to the medial quadrants, any superior, inferior, medial quadrant, then they have good chances to go to internal memory lymph node, because that is close to it. These internal memory nodes have a propensity to cross midline and reach the contralateral breast. So tumor is starting on one-sided, on say on the left side over here. In later stages, if not appropriately treated, can go to the right side as well. It will become bilateral carcinoma. Okay, so do remember this as well. Then obviously from here can go to the subdiaphragmatic nodes into the peritoneum, can also reach the mediastinum other levels. So clinical standpoint, you can say that to be more precise, breast we divide in 4 quadrants. Superior lateral, most commonly carcinoma happen in this quadrant and they drain to the axillary lymph nodes. Fair enough. But if the carcinoma is to the medial aspect, it will obviously go to the internal memory, because that is nearby. Now, which has a propensity to go bilaterally to the other side. That becomes clinically important. Okay, so do remember this point as well while writing. There is all this theory that we have discussed. Superficial drainage, that's also one more classification. We might divide this whole lymphatics into superficial lymphatics and deep lymphatics. Superficial lymphatics is for the skin except nipple, and deep for the deeper part. And then you can just go through this, which quadrant will drain where. Okay, this is again very, very important for your theory exam. Breast self-examination. Why? As we just said in the beginning, that breast carcinoma are the most common carcinoma worldwide. So the only way to prevent from this in your home, in your nearby relatives, every female should know how to self-examine the breast over here. All the steps are given, a lie on a back and put. Basically, the point over here is to relax the tissue and then softly palpate each quadrant and look for any nodes or any hardness, any lump, any growth. Feel it inside your breast tissue. And if anything, and also look at the shape of the nipple, the retraction of the skin or the nipple, that also has to be examined. Okay, if any change is noted, then obviously go to your nearest doctor over here. That is all written over here. Lie on your back and put your right hand behind your head. Putting the right hand behind your head obviously relaxes. Use the left hand to press down to examine the right breast. So once you have exposed the entire tissue and then you're examining, apply light, medium, and firm pressure to check for layers. Sit up and press into your right armpit to check for lumps. Now, why is this needed? Understand anatomically. They are saying over here that sit up. Now sit and press into your right armpit to check for lumps. Armpit is the axillary region. Lumps is lymph node, lymphadenopathy. Squeeze your nipples to check for any discharge. Okay, lie back down, switch arms, and repeat on the other side as well. So that is very important for the breast examination, right? Breast cancer, as you have seen already, that is already the most common carcinoma worldwide. Fair enough. Now, moving to this muscle pectoral region, let me just go through, guys, this some of the other important points are left from the breast part. Just a second. Yeah, here it goes. See over here. Now here some points are written. Let us just go through them. This is just a difference of a male and a female breast. The main difference is in male breast, the acini are absent. Male, see, remember, we only keep in mind, okay, female breast and female breast carcinoma. Males are also, exposed to the carcinoma of the breast, although very rare, but it can happen. The only difference in male-female breast is male breast has less fat and and no acini. So there's no milk secretion from there, right? Now look at this image. This image is a sagittal section showing you basically what these ligaments of Cooper, as I told, just for prevention of sagging, and it goes from dermis to the deep fascia, that is behind the breast, right? Because breast is in the superficial fascia. Thus, we are seeing all these acini in the ducts, and ducts are opening where into the nipple over here. Then these are the arterial supply we have already seen. Yes, here is this image. This I wanted to show you over here. This is a clinical scenario over here. Now, as we are discussing, okay, breast carcinoma, and they are very common, fair enough. Now, see what happens is, if the cancer, point number one, if the cancer involves these ligaments of Cooper, the patient might present as a dimpling of skin. Okay, because cancer will be pulling on the ligaments of Cooper, and from the outside, what you will see? You will see the dimpling of the skin over here. Point number one. Second point is, if the cancer is involving the lactiferous ducts, then they will pull on the nipple. Patient will present as retracted nipple. Nipple will retracted. And third point, very important, you might have heard of a term known as PUD orange. There's also you have to write in your clinical applied. If the cancers they involve the cutaneous lymphatics, there will be skin edema that is known as PUD orange. So these 3 points to them, very important for your theory exam, right? Okay, here's a question. Question goes like an 80-year-old lady comes to the physician because of a lump in her right breast. Examination shows a 2 centimeter mass in the right breast with the dimpling of the overlying skin and PUD orange. Examination of the biopsy confirms a carcinoma involved under what structure is the most likely cause of the patient's skin dimpling. See, now we have just seen this image. We know dimpling of skin, retracted dimple, and PUD orange. They were asking skin dimpling. It is basically your ligaments or ligaments of Cooper. Search for that suspensive ligament. Option B will be a straightforward answer over here. Okay, so easily reach the answer, right? Fair enough. Okay, now let's see the other topic over here. So this was all about the breast. I hope it is sufficient for the breast part. That is, let's move to the other muscles of the pectoral region. Now, breast itself is lying in the superficial fascia. Okay, way in the front of chest. So pectoral region is obviously right in the front of chest. So pectoral region forms the anterior chest wall. Here it is the anterior chest wall. Fair. Now, pectoral muscles include from superficial to deep. Most superficial, you have the pectoralis major. It is most superficial. If you cut this muscle, you reach P minor. And as you see on reach on the posterior or lateral aspect, you see serratus anterior. And the subclavius, I am sure you guys might remember it. We have done this in the when we are doing the bone clavicle. It is actually very small muscle, just inferior to clavicle. It is very small muscle inferior to clavicle with no major actions. Let me tell you that also. Let us see one by one all the muscles. Pectoralis major muscle. It's a huge muscle. It's a huge muscle. First of all, let me show you the image of it. See, the origin of the muscle is from here. From where? From the clavicle. From this part of the sternum. From the ribs over here. And as you go below, what do you see? You have the external oblique muscle from its aponeurosis. So it has a clavicular head of origin, right? It has a sternocostal head of origin, and below you might also call it as a aponeurotic head, because it is arising from the aponeurosis of external oblique. So origin is huge. Origin is huge. What happens is, as we go from medial to lateral to reach the insertion is obviously less in extent compared to origin. And actually the insertion over here, the muscle goes into this U-shaped insertion. The U-shaped insertion. So insertion, there is folding, which you can also feel on your side of chest over here. This pectoralis major muscle. Where is it inserted? It is inserted into the lateral lip of bicipital groove. Lateral lip of, so you can say bicipital groove. You can say it as the intertubercular sulcus. Intertubercular sulcus or groove. So lateral lip of intertubercular sulcus. Let me remind you, day for yesterday we discussed what? A lady between two majors. One was P major, one is teres major. This is P major on the lateral aspect. So it is going into humerus, coming from clavicle and sternum and ribs, going to humerus. Now think about its action as well. Before, if we want to see the nerve supply is very simple. It is supplied by pectoral nerves, both medial and lateral pectoral nerves. Simple as that. Origin insertion, I told you. Origin clavicle, sternum, ribs, bit of aponeurosis, insertion into the lateral lip of bicipital groove. Action is what is important. If this muscle contracts, what will happen? Muscle contracts means, suppose this muscle is having 15 centimeters of the width. Contracts become 10 centimeters. So when the muscle will contract, they will be obviously going to the movement of upper limb movement will be there. Which movements will be there? Think common sense. Apply common sense over here. Upper limb will come close to the body, so there is adduction of the upper limb. Upper limb will move in front also. So this movement will be there. So one movement is coming close. So that is adduction. The one movement is this. So that is flexion. Okay. And also there can be slight rotation of the upper limb like this. So that is known as medial rotation. These are the major movements of the P major. There are other additions as well, but first understand this point. Let us come now to the topic. So it is superficial fan shaped muscle with sternoclavicular head. Attachment of P major includes sternal head, clavicular head, and intertubercular sulcus. That is the insertion point. Okay. Function, as we said, flexion. It is not adduction, it is adduction and medial rotation. Simple as that. and nerve supply lateral medial pectoral nerve. Simple as that. So this is P major for you. When will you find it? First, you remove the skin fascia and you remove the nipple and the areola structure. If in female, you have to remove the breast. The moment you remove the breast, what you will find over here is you will find a fascia that is known as pectoral fascia. Once you cut the fascia, you have this muscle fibers. That is the location, right? That is P major for you. For P minor, as I told, that once you remove the P major, you will see the P minor. I will show you. Once you cut the P major, you will see the P minor. In this image, let me show you over here. Let me show you in this image only. Just a second. Let me just. Okay. Okay. In this image, let me show you where would be the P minor. P minor actually arises from the base of coracoid. Now, this you can see this is coracoid process. So it rises from the base of coracoid, goes to third, fourth, fifth rib. So this will be around third, fourth, and fifth rib. So if I make a muscle over here, let me use say this color. If can we see it? Yes. This deep muscle over here. Can you imagine it? This green line which I'm making, let me make simple like this. This green line muscle, imagine it is deep to P major. That is P minor. That is P minor for you. Let us see. So P major minor forms the entry wall of axilla. Fair enough, not bad. Then we have attachment from third to fourth rib and goes to coracoid process. Function is basically it stabilizes the scapula by drawing it anterior inferiorly against the thoracic wall. Basically stabilization of scapula. And innervation is basically our medial pectoral nerve. In P major, we had both medial and lateral. Here we had both medial lateral. P minor, we only have medial pectoral nerve. Now here you can see this image. P major has been removed. This is P minor. And again, I'm telling you, it is the key muscle in axilla. It is a key muscle of the axillary region, Don't forget. Why is it key muscle? See, it is key muscle because it is used to divide the lymph nodes, level 1, level 2. It is used to divide the axillary artery that also you will see. Level 1, level 2, level 3 axillary artery. Okay, so axillary artery and lymph nodes, they are divided on the basis of this muscle. Let us see. And the muscle subclavius, as we just said, it is just present below the clavicle. So this is the clavicle bone over here. Below the clavicle, this is subclavius. Functionally not very important over here. You might just write anchors and depress the clavicle. It won't be wrong. Attachment from first origin from below, you have the first rib and inserts into the inferior surface of the middle part of the clavicle. Here we had the subclavian groove. Here we had actually the subclavian groove, which helps in identifying the side of the clavicle. Like the subclavius muscle over here. Then comes this huge muscle, serratus anterior. I will show you these other diagrams as well. It's a huge muscle, very, very important. It is also known as boxer's muscle. Boxer muscle. Boxing, main action in boxing is what? Pushing and punching, right? So boxer's muscle, punching. So now you understand the action of this muscle. It's a pushing and punching action. That is why it is known as boxer's muscle. If you look at the video of any of the boxers, take any small video, any boxers, once they give a punch like this, look on the sides, okay, on the side of the chest, you'll see some V-shaped serrations, right? All those are serratus anterior muscle. Okay, look on the lateral chest wall. Once they're punching, you'll see V-shaped serrations, multiple serrations, V-shape. That is the serratus anterior muscle. Okay, so it has around 8 digitations. You'll see muscle has several strips, rises from the lateral aspects of rib 1 to 8. They attach to the posterior surface of the scapula and they reach where? Scapula. Scapula we have seen. You'll see more. Action is what? It rotates the scapula. Arm can be raised above 90 degrees. It protracts. This protracts is pushing. It pushes the scapula holding against the ribcage. So it helps in two things. One is, as we discussed, pushing, punching. Second is also helps in overhead abduction. Now, what is overhead abduction? Suppose you have to reach the top drawer of your almirah. So you have to raise your hand like this. Overhead abduction. This is overhead abduction, right? This is 90-degree abduction. This is overhead abduction. So for overhead abduction, we have this serratus anterior that helps in the overhead abduction. Two actions. Nerve supplies long thoracic nerve, and if I may ask you the applied part, it is winging of scapula. This muscle, if it is paralyzed, it leads to winging of scapula. Let us see the muscle over here. Okay, they are showing the P major, but don't worry, I will show you the image over here. This is a table which you can go through all of these 4 muscles. This is simple tabular form. P major minus subclavius serratus anterior. Subclavius not that important, let me tell you, but the rest 3 are very, very important. So go through the origin, insertion, or supply action. That is important, right? Now, let us see those muscles in this another format. Now, let me show you the muscles over here. Just a second. Okay, fair enough. Moving ahead from this. Yes, here we have these muscles. So let us quickly revise what we have just seen. So this muscle over here is which one? This is P major muscle. Pectoralis major muscle, showing you all the clavicular head, sternocostal head, all these heads. Inserting over here. This muscle is deltoid, another important muscle. And there's one more structure shown over here, cephalic vein, which runs between deltoid and P major. But let's move forward from here. Again, you can see, can you see this twisting of the insertion fibers? Okay, this U-shaped attachment over here. That is our P major. This is our pectoralis major. Don't forget it. Okay. Now deep to it, if you cut the P major, so P major has been cut in this diagram. Deep to it, you are seeing this major muscle. This not this major, but this muscle. This is P minor. Let me switch to the black color over here. This is P minor, P minor. Deep to P major, and the small muscle below the clavicle. This is subclavius. These are the arm muscles, biceps and all different things. Okay, biceps and all these are different things, right? And on the sides, if you start seeing on the sides, can you see this digitations over? These are serratus anterior. We'll see more, don't worry. Okay, so serratus anterior shown anterior after removing the P minor. So in this image, P major is removed, P minor is removed, even subclavius is removed. So and the arm muscles also removed. On the sides, can you see these digitations? These are all serratus anterior muscle. These are all digitations of serratus anterior, and you can see this long nerve coming down, known as long thoracic nerve, supplying the serratus anterior. This is from the front view. Now, can you trace this? If I trace the scapula will be somewhat like this. Am I correct? Posteriorly, scapula will be somewhat like this. And just to keep on doing this, and if I start the muscle from here, this is actually from where the serratus anterior is coming from behind, in front of the scapula. Meaning this is the middle border of the scapula, right? Anteriorly, from here the serratus anterior rises and it goes around and it inserts into this upper atrium. So it goes around and inserts like this. This is serratus anterior. Therefore, when this muscle will contract, it will pull the scapula forward. So helping in your pushing punching movement. Understand this. Pushing or punching movement. Are you getting a point? I hope we have some. Yes, we have one more image over here. Now this image I'm sure is going to help you understand. This scapula, so this posterior, this is anterior sternum anterior. So this which view? It's a lateral view. Understand this. All the muscles are removed except serratus anterior. So the serratus anterior is coming from here. Can you see this middle border of scapula on the front side, and this is inserting into these ribs. Now see, imagine when the muscle will contract. This is the glenoid cavity. Upper limb is attached over here. Pushing, punching. This image also similar thing. You are seeing this whole muscle as serratus anterior. This is the scapula over here. This whole serratus and huge muscle. Beautiful muscle. We also see in a dissection. It is a beautiful muscle. Okay, and this is obviously the scapula over here shown, right? So yes, coming on to the other part. I hope the serratus anterior muscle and all is fine now. Let's come to the topic of axilla. Axilla in simple words. What is axilla over here? Let me simple words. It is just a passageway. Let me put in my words. It is just a passageway. It is an area, obviously, a passageway between which two structures? Between upper limb. Between upper limb and say neck region. And neck region. So what actually happens is upper limb is actually a appendage. Listen carefully. Upper limb is actually a appendage. It is a projection outside the body. The main body is head, neck, and trunk. Upper and lower limb, they are appendages. So upper limb is an appendage. Now this upper limb having obviously the living tissues. It will need artery, it will need vein, it will need nerves, it will need lymphatics, lymph nodes. So they have to reach the upper limb. So artery has to reach upper limb and the blood has to come back. So vein has to come out of upper limb, right? Similarly, the lymphatics, they have to come out of upper limb. So, and what else we said? Yeah, lymphatics and nerves. Nerves have to reach the upper limb. Motor nerves and sensing nerves have to come. So, connecting the whole body, which has all these important systems, and the upper limb, we have made a passageway through all these vessels, lymphatics, nerves can easily pass. That is known as axilla. That is known as axilla. Just simple. right? Now this image you might find somewhat difficult to understand, but understand over here in this particular image, this side is shown as anterior, this is posterior, this is, you can see the humerus over here, so lateral, and this is the ribs, so medial. Now imagine this is actually suppose a person is sitting on a chair. Okay, a person is sitting on a chair over here like this, right? Person is sitting, let us say this is the body, trunk and all that, lower limb and all that, right? First sitting. Now what you do is you're standing behind the chair, right? And you look at the top of shoulder or the top of left shoulder. Just imagine a person sitting on a chair like I am sitting, and someone is standing behind my chair, and they are looking at the top of my left shoulder. So this view is like that. This view is actually a superior view. It's actually a superior view, particularly on the left side. And just imagine the skin fascia all has been removed. So what is left? You have an anterior side, you have P major minor, anterior P major minor. Behind with the attachment of scapula, you have muscles like subscapularis, teres major, latissimus dorsi. On the lateral, you have this humerus, glenoid cavity. If you go medially, so see, P major is going like this, okay, and the scapula they are going like this. So it is making an angle. So they are converging laterally. Laterally, you have this humerus or the glenoid cavity. So anterior posterior borders or anterior posterior wall, they are converging laterally. Medially, what is happening? You have the ribs. So all these are medial. We have the ribs. What is attached is the serratus anterior muscle. That is it. In between, what we will have is in between, we will have the contents of axilla. This is a superior view for your understanding. Okay, this helps you understand what all the walls, because this is what you have to write in theory. Anterior wall, posterior wall. Just go through it 2-3 times if you are not yet gone. It will help you in revision. And this is what you have to answer in this format. Anterior wall, what is the apex? The apex will be at the top, at the neck region. So apex is what? Apex is at the neck region. So it is known as what? It is known as cervico-axillary canal. Base is this armpit area. This armpit over area, that is known as base. Okay, this is known as the base of axilla. Because the base is at the region of armpit. So posterior wall, anterior wall is what you can write. This is actually twice it is written. So this over here is not the base, it is the anterior wall. It is the anterior wall over here. Okay. Don't worry, I'll show you a couple of more images. Just go through it. Medial wall is what? You had the ribs. So medial, just remember you have the ribs, and basically the upper 4 ribs are there. Serratus anterior was still the 8 ribs, but axilla only upper 4 ribs. And lateral wall is what? See, lateral wall, the anterior posterior wall, they are converging. So P major and teres major, they all were converging where? Into the intertubercular sulcus. So that will be your lateral wall. So lateral wall is biceps in the bicipital groove. This bicipital groove is intertubercular sulcus. So lateral wall is that small sulcus. Why? Let me tell you again, show you this image. See, where is P major inserting? Into the lateral lip. This is the lateral lip. And where is T major inserting? Into the medial lip. So see, this small area over here, which I'm encircling, this is actually only, this is the lateral border, also known as bicipital groove or intertubercular sulcus. So lateral border is very thin. Anterior, posterior, they are diverging. And medial, you have this ribs. Okay. I hope you are somewhat convinced. If not, don't worry at all. Don't worry at all. We will be seeing an image for you to understand the axilla. Here it is. A better simplified image. So what to see over here? See. It is very simple to understand. This is, you can see this green highlighted area. This is the area or the region of axilla. You can see from the neck, the nerves are coming. You can see this red and blue. These are the vessels, both artery and vein. This yellow color, they are the nerves forming the brachial plexus, and they have to reach the upper limb over here. So this passageway between the upper limb and the rest of body, basically the neck region over here, this is the axilla region. If you have to understand the boundaries, what we did, we looked from above. We looked from above down. So what we saw is anterior, you have these muscles, you have some P major and all. Posterior, you have the muscles from the scapula. Lateral wall is only this intertubercular sulcus, and medial, you have this. How many ribs? 1, 2, 3, and 4. Medial, you have the medial 4 ribs. Okay. Now, just to see one more image. It is the same image like this. Just over here, the artery, vein, and the nerves are also shown. What is missing over here is the lymphatics and the lymph nodes. They are not shown, as I got confused. This is the axilla. Once you understand axilla in this way, this is a sort of similar image. But in this image, what is also being shown to you Here is the difference. What this is the anterior side now, because you are seeing P major minor, that's the posterior side, lateral and the medial side. Here the contents are also shown. In contents, basically what? Artery, vein, nerves, and lymphatics, lymph nodes. That's it. That are all. Those are all the contents. Okay. So just for your understanding, see these sessions we have placed for your better concept understanding. We know that you know the answer, you are right. But there is a difference between being only writing the answer and being confident in writing the answer, being confident in giving the viva. Here is the difference, and this difference is what we are over here to make that small leap for you so that you develop that more confidence. What's the use of that confidence is obviously better understanding of the body. Because once you pass through the first year, all those remaining 3.5, 4.5 years, you have to understand the whole body again and again with the help of some diseases. So once your base is strong, your whole MBBS, your whole future, your whole career there, that will obviously go in a very, very nice way. Okay, so we are helping over here the base. Because that's the most important. Contents of Excel already told you. There's no need to think too much. It will have, obviously have what? It is going to have vessels, both artery vein. It is going to have nerves. It is going to have lymph nodes and lymphatics. That's the main content is what you have to focus over here. Apart from this, you have fatty tissue, you have connective tissue, you have fascia, and all that is fine. This is what the main content you have to understand. Okay. So contents, they have artery, vein, nerves, lymph nodes, and then these are the other small contents. But upper four contents you need to understand. Then the question might come about the axillary artery. Write a short note on the axillary artery, its branches and relations. So axillary artery, there are 2-3 things which you need to know. First of all, why this separate name? Separate name is because what actually happens is, see guys, you have an artery going from say one area to second area, right? There's an artery which is traveling. Fair enough. Okay. Now see what happens is anatomically we have divided, say this is region A, which is green color. This is say neck region. Okay. This is say region of axilla. Okay. Just highlighting in this is the region of upper limb. Okay. Artery is same. Don't worry much. So over here in the region of neck, we will call it as subclavian artery. Artery, again, I'm saying it is same. The same artery reaches the axilla. Okay, we can't still call it subclavian, so we are calling it axillary artery. The same artery reaches the upper limb, so we will now call it as brachial artery. First of all, remove this doubt. Artery was same. There was not a difference in the artery. Artery was all the time, it was the same artery that was going from one place to other. Now see, what was the main structure or the key structure in the axilla? It was the muscle. The name was what? P minor muscle. So now this P minor muscle will do what? Will divide the artery into first part, second part, third part. Simple as that. And they will give branches. It is as simple as that. So now as you know the extent of axilla, this is the region of neck. So we are saying that from the neck, it was the region of subclavian artery. Now, as it will cross the structure over here, that is first rib. Which rib? First rib. Because remember, the upper 4 ribs were a part of medial wall of axilla. So as it crosses the first rib, it becomes axillary artery. And over here, as it crosses the lower border of teres major muscle, bracket I'm writing lower border, it reaches the upper limb, and now we'll call it as the brachial artery. So it is from first rib area over here. Let me repeat again. It is from first rib area to the teres major lower border, that this artery is known as axillary artery, divided by this muscle P minor into first part, second part, third part. Simple as that. Now let us see what is written over here. Begins at the outer border of first rib as a continuation of subclavian artery and ends up becoming brachial artery. This 2 lines you have to write in your exam. If the examiner reads these two lines, the examiner knows, okay, you know the basic concept. Then divide into 3 parts by P minor, first part, second part, third part. Then what is left is the branches. The branches you have to write, and better to make it a diagram also. See, now sir, how can we make this diagram? Don't worry at all, guys. Making diagrams is very, very easy. Let me just tell you, you should know the extent of it. So what you can make is, you can make quickly a sternum over here. Okay. Then from here, you have which rib? You have the first rib over here. And what was the structure going from here? That was, say, the clavicle over here. This was the clavicle, right? And here, you can just make second, third rib, and if you wish to. Here, then you can make this as, see, this is the clavicle, right? So this is, say, the coracoid process. Quickly you can make, and you can make a muscle over here, P minor muscle. Simple, you can make a P minor muscle, and just to add on to it, you can make a T major muscle going over here if you wish to. If not, no problem. Then you simply have to do what? You simply have to make an artery going like this. Is that simple? Nothing doing. If at all you want to, you can make this artery over here. Just label this over here as a subclavian artery, not needed though, but this whole artery is the axillary artery. And then what you can do is you can just follow some of the total 6 branches. You can make some 6 lines and just label them. So bony landmarks are what? You should know 2-3 things. You have to make the first rib. To make it, you should make the sternum and first rib covered by clavicle. And here you can make the P minor just to divide the artery into 3 parts, part number 1, 2, and 3. So first rib is sternum, first rib, P minor muscle, make a red artery, show 5-6 branches coming out of it. That's it. And then you can name the branches. Branches name are very simple. Okay. Here you have, these are the relations of the axillary artery. The relations of the axillary artery are obviously quite tough for to remember. But once and all you will understand the axilla, how the organs are related to each other, then you might write it. For example, axillary artery. Just imagine how to write the relation. Suppose you have no idea of the relation. What will you do? Over here, you just have to have an additional knowledge of what? Of the thing that middle to the axillary artery, you have axillary vein. Here you have the structure that is known as axillary vein over here. So axillary vein is medial to the axillary artery. Then what is left are the nerves over here. And you can just imagine, okay, axillary artery surrounded by the nerves of brachial plexus. That we'll see later on what are the different parts of brachial plexus over here. So this whole artery is related to which muscle? P minor. Which muscle was covering P minor? P major. So you know in anterior relations, you'll always have what? You will always have the P major. Okay. So anterior relations, mostly you have this P major over here. Here is P minor. Again, P minor covered by P major. Okay. Third part also you will have P major. So P major will be always there. Medially, you always will have the axillary vein. I'm just trying to help you how you can write it, right? So medially, you always will be having the axillary vein. And slowly, as you will go through the brachial plexus, you will understand that this axillary artery over here, okay, it is surrounded by, it has the trunks, okay, then the 3 cords, lateral, medial, posterior, and their branches and all. So it is most of the time surrounded by the cords of brachial plexus. So axillary artery is surrounded by brachial plexus, and also do remember that they are all covered by this common what? Sheath over here. And what is that known as? That is known as axillary sheath. So let me just complete it. You have an axillary sheath which is having the axillary artery inside, surrounded by all these nerves over here. Then you will slowly understand the relations. Coming to major part, that is the branches of axillary artery. Branches are simple. Let me just try to tell you over here that, see, axillary artery has 3 parts. Part 1, part 2, and part 3. Part 1 will give 1 branch. Part 2 will give 2 branches. Part 3 will give 3 branches. Total there are 6 branches. Part 1, part 2 will give 2 branches. Part 3 will give 3 branches. So total there are how many branches? 6 branches. How to remember their names? See, there's a mnemonic over here written. Sometimes, let me just highlight it. Sometimes life seems a pain. Sometimes, okay? It only seems, it is not a pain. It is just your hard work and struggle, right? But that mnemonic can help it. Sometimes life seems a pain. What is that? Now see, let's name them. S is for superior thoracic artery. First, let's see the name. T for thoracoacromial. L for lateral thoracic. Remember, this artery was supplying the mammary gland. Then S for subscapular artery. And this A and P are for anterior posterior circumflex humeral artery. Okay. Now let's see that in the image. This is written over here as part 1. Okay, part 1. Part 2 is behind the P minor, and part 3. So 3 parts of axillary artery, part 1, part 3. Part 2 is where it is not covering P minor, it is behind the P minor. Now see, this is your first rib over here, if I may write again, rib number 1. And here is the T major shown, and this is the, after this is a brachial artery one. So first part of axillary artery is close to the upper part of thorax because this is first rib. So it gives off a branch that is known as superior thoracic artery, was in the upper part of thorax. Second part is going known as thoracoacromial artery. Over here, you have a trunk of thoracoacromial artery over here. And you going down, that is the lateral thoracic artery. So this over here is the lateral thoracic artery over here going down. Lateral part of the mammary gland. Thoracoacromial kyun? Because it is in the thorax, and with coracoid, you have the acromion process as well. So first part, superior thoracic. Why? Because upper part of thorax region. Now see, artery is going from medial to lateral side. So as the third part will come, it is coming close to the bone humerus. So it is giving what? It is giving circumflex humeral artery. They will circumflex, so they will curve around the upper end of humerus. And then you also have the, now you are coming below also. So as you are coming to third part, you are coming lower down. So it will give off subscapular artery at the lower part of scapula. It will reaches the lower part of scapula. So sometimes life seems a pain. Fine, just read these branches 4, 5, 6, 7 times and just understand for a second that why we have named it like this. Can we name the first branch as inferior thoracic? No, no, because it is in the upper part of thorax. Humeral branches are from the third part. Why? Because third part is reaching the humerus. So humeral branches are third part. And as we reaching the third part, we are going down also. So we have subscapular, not suprascapular. It is subscapular. This way we can understand the branches, right? Let me show you in some other images as well. Here we have, just a second. Yes. Okay. These are the 3 parts written over here. Let us just go through it quickly. This is first part, that is second part, that is third part of axillary artery. Second part is behind the P minor, don't forget. Continued from subclavian and continues as brachial artery, and these are the branches. Okay. First part is known as superior or supreme thoracic, same thing, part number 1. Part 2 is giving thoracoacromial from part 2, and this is lateral thoracic from part 2 only. Part 3 is going down, so you have circumflex part 3, and you will have the largest branch, subscapular. Don't forget that it is the largest branch of axillary artery. So subscapular branch is what? It is the largest branch of axillary artery. Okay. Now this is which view? We are looking at a posterior view. Okay. We are looking at a posterior view. Now here, let me tell you the applied part also. Just remembering the branches is not that much fun. The fun lies over here. See this. Now suppose this is the artery. Very good, right? Just give me 1 more minute. Okay, so you'll understand the topic over here. The point over here is, suppose there is some lymph node, because there are a lot of lymph nodes over here. Suppose there is a lymphadenopathy or an infection, lymphadenitis, whatever, there's the artery over here at any position, it gets blocked slowly. If the artery starts to get obstructed and blocked with an external compression, the blood supply to the upper limb will be lost. Upper limb might go into necrosis because there is no blood now, or there's very less amount of blood. It will start with pain, pulselessness, paresthesia, all those 5 P's, and slowly it might go to gangrene and necrosis. So we have to keep the blood flow to the upper limb at least patent, even if this axillary artery is blocked anywhere. Because what's the crime of upper limb? If artery is getting blocked in axilla, upper limb has done nothing. Why should upper limb be devoid of blood supply? To prevent this devastating outcome, what happens is, around the scapula, you have an anastomosis which starts to develop. So the question comes about anastomosis around the scapula. What happens is that from the subclavian artery, few branches will come, and from the third part of axillary artery, few branches will come, and they are going to anastomose around the scapula, such that if the artery is blocked over here anteriorly, the blood might from subclavian might come to the scapula, they might anastomose, and from here they might go to the upper limb in the form of brachial artery. That is known as anastomosis around the scapula. And which branches are involved over here? Let us quickly see. From the subclavian artery, we basically have this transverse cervical and suprascapular artery over here. Okay, transcervical also can be called as dorsal scapular artery. So let me just write over here. There's also known as the dorsal scapular artery. Okay, that is one thing. And from the third part of axillary artery, we have the subscapular artery, and its branch, the circumflex scapular artery, might be written somewhere. If not, then let me write. Okay, it is written like this over here. Okay, so this subscapular artery and circumflex scapular, the anastomose is suprascapular and dorsal scapular arteries over here. In mostly in cases of axillary artery obstruction, such that the blood flow to the upper limb is continuous. So blood flow to the upper limb is continuous like this over here, from here to here. That is a point which might be asked, and you should better be prepared for it. Fair enough? Okay. Let's come to the notes part and see what else we have over here. So this is the axillary artery. Okay, and yeah, these are all the branches. First part, second, or third part. Let's go through one or two lines over here. Now, axillary vein is the topic that might come, not that important, but that might come. Remember, axillary vein lies medial to axillary artery. That is one thing. And obviously, it is draining the blood from the upper limb and the lateral thoracic vein. Just go through it. It is formed by the union of basilic vein and the vena comitatus of brachial artery at the lower end of teres major. Basilic vein and cephalic vein, you will see them in the upper limb. Basilic vein is actually a part of superficial vein, but it slowly pierces the fascia, becomes the brachial vein. And as see, it is very simple give and take relation. As axillary artery became brachial artery, in similar words, the brachial vein, once it comes back, it becomes axillary vein. Simple give and take relation, nothing more than that. Tributaries of axillary vein will be coming from below: lateral thoracic vein, subscapular cephalic vein. Okay, cephalic vein comes from the upper limb. Write a short note also. Axillary vein is this. Axillary vein, we can have a diagram also over here. And just give me a second. Yes, here. This over here. This just see to it once. Then you might appreciate that this is the basilic vein. As it is progressing upwards, becomes brachial vein, and that brachial will become axillary vein. Simple as that. Let me change the color to blue for us better understanding. This is the cephalic vein, that is superficial vein. Which vein? Superficial. And I told you once that this vein runs between the deltoid and P major over here. P major, not minor major. Cephalic vein. It is superficial, then it curves 90 degrees and it drains into axillary vein. Okay, so this is your vein over here, and you can see the relation of vein to the artery. This is the artery over here, and this is the vein. You can see the vein is lying medial to the artery, and this again will continue in the neck as which vein? Subclavian vein. Subclavian vein. So like subclavian artery, axillary artery, brachial artery. We have brachial vein, axillary vein, subclavian vein. Simple as that. But remember, the axillary vein will be outside the axillary sheath. Will be outside the axillary sheath. Fair enough. Okay, and you can see this group of lymph nodes also. This image also. Majority of these lymph nodes, which you have just studied as a group of axillary lymph nodes, they are around the vein. Which vein? Axillary vein over. This is the vein over here. Majority of the lymph nodes. See, lymph nodes are not scattered like this. What is connecting them? Connecting them are the lymphatics, which are so small like capillaries, you don't see them, but they are connected by lymphatics only. And the lymph nodes majorly found around the veins. Okay, fair enough. Right. Now, axillary lymph nodes, I guess we already have done this. 5 groups, and you have levels also, which we have discussed. Applied anatomy, obviously, needless to say again and again about carcinoma of the breast. If you go to surgery ward, you have see a breast patients. Obviously, you also see, always look at the residents, what they are doing in examination. They're always examining the axilla. They're palpating the axilla, looking for the enlarged axillary lymph nodes. Okay, so keep your eyes and mind open when you're going through the wards as well. Axillary abscess, so you can give an incision, you can drain the abscess. Fair enough. Okay, now next topic is the brachial plexus over here. Brachial plexus, that is the main nerve supply to the entire upper limb. Okay, main nerve supply to the entire upper limb. We'll just give an overview over here. Next 5 minutes, there's the last topic over here. Brachial plexus is coming from the first thing, remember, coming from C5 to T1. So we have C5, C6, C7, C8, and T1. We are talking of the nerves, which are the ventral rami over here. You're dealing with nerves. So what is it going to do? It's not only going to give the motor supply to the muscles of the upper limb. In fact, it is also giving the sensory innervation to the upper limb. That is also as important as the motor supply. So this whole brachial plexus is going to give motor supply, sensory supply, and sympathetic. Why, sir? Why sympathetic? For sweat glands. for blood pressure management. Okay, you measure blood pressure over the brachial artery, sympathetic. Okay, so plexus of nerves formed by the anterior, that is the ventral rami of the lower four cervical, C5 to 6 to T1. It starts from the neck, obviously. Then see what happens in the brachial plexuses. The roots, they will form the trunks. The trunks, they divide into ventral dorsal divisions, and these divisions, they form the cords. And finally, on the cords, we have some branches. Okay, this can be remembered by a right to drink chilled beer. Right to drink chilled beer, or real teachers drink chilled beer, whatever you can say. So just a mnemonic over here so that you remember right to drink. So you need to know the sequence. Chilled beer over here. We are not promoting any beverage over here, but just for your remembering. Right to drink chilled beer. Right R is for roots, 2 is trunks. So there are 5 roots, and trunks are 3 over here, upper, middle, and the lower trunk. Each trunk will have 2 divisions, total 6 divisions. So drink deep divisions. Chilled C is for chords. So we have 3 chords as a lateral, medial, posterior in C, and they then gives rise to various branches. These branches are given off by the root and trunk as well. Okay, but chords and branches, the branches going to the upper limb. Okay, fair enough. So all this written, see over here. Let me show you, this is a better understanding. This is the baseline of the roots over here. So see, roots here, C5, C6, C78, one. C5 and C6, they combine to form the superior or the upper trunk. Remember this, superior or the upper trunk. C5, C6 combine to form the upper trunk. C7 forms a middle trunk. C8, T1 forms a inferior or the lower trunk. So this is upper trunk, this is middle trunk, or this is lower trunk. You can call it as superior, middle, inferior also, no worries. Each trunk divides into ventral and dorsal division. Ventral division is shown by this dark color, that is the ventral division, dorsal by this yellow color. So dorsal, dorsal, dorsal. So there are 5 roots. There are 5 roots, right? There are 3 trunks. So and circle 5 and circle 3. And out of 3 trunks, you have 6 divisions. And finally, you have 3 chords. Just see how. So 5 roots, 3 trunks, 6 divisions. Now see, all the dorsal divisions, yellow color divisions, they form the posterior chord. Chord number 1 is posterior chord. It is the thickest chord. The ventral division of upper middle trunk, they form the lateral chord. And the ventral division of the lower trunk will form the medial chord. And then these chords will have different branches. Only 5 branches are shown over here. These are the basically, we can say the 5 terminal branches, but there will be other smaller branches as well. 5 terminal branches are these. Why terminal branches? Because they go to the arm, forearm, and the hand region. Like musculocutaneous, axillary, median, radial, ulnar, they go to the forearm, arm, and the hand region. So they are known as 5 terminal branches. Now see over here, the catch point over here is for you to understand and visualize. If we look at the medial chord for a second, it is coming from where? It is coming from the ventral division of which trunk? Inferior trunk or lower trunk, whose root value is C8T1. So therefore, medial chord will have C8T1 only. There's no contribution of C5, C6, C7 on the medial chord. Agreed or not? Exception over here will be that some C7 fibers reach the ulnar nerve. That is different thing. But normally, if you look at the medial trunk, the medial chord, sorry, you'll only see the C8T1 going to the medial chord. Similarly, if you look at the lateral chord, ventral division of upper and middle trunk, upper and middle trunk. So it will have root value of C5, C6, C7 only. The lower trunk is not going to lateral chord at all. Try to think. Now, lastly, if we look at the posterior chord, it is having dorsal division of all the 3 trunks. So it can have C5 to T1 complete. Maximum, this will be the root value. That is the whole catch point, right? And this all is happening where? This all is happening around the axillary artery. So if I make, say, over here, this is the right highlighted part. This is, imagine the axillary artery running in the axilla. Just imagine for a second. Okay. So the cord which will be lateral to the axillary artery, the thick cord, that will be known as lateral cord. The cord that is below the axillary artery will be the middle cord. And if you just lift the axillary artery, the cord which you see behind it, that will be the posterior cord. This is how you recognize intersection. All this happening, therefore we say that axillary artery and the brachial plexus, they are running in a common sheath known as axillary sheath. And vein is actually a bit outside. That's the deal over here. Deal is that the vein is a bit outside more on the middle. This is the axillary vein running. Okay, so right to drink chilled beer, remember? Root, trunk, division, cords, and branches. Branches, there are others, but remember 3 cords, how to recognize them. And do remember that division over here, last point of the day. I'll say it will too much of knowledge for you. Remember the division over here, it is actually close to a structure that is known as the clavicle. So this region is of clavicle. So the point over here is that the root and trunk, if I may write in a empty space, let me utilize this one, that the root and trunk, root and as well as trunk part of the brachial plexus, they are known as supraclavicular part of brachial plexus. What are they known as? Supraclavicular part of brachial plexus, because they're above the clavicle. While the cords and its branches, they are known as infraclavicular part. Infraclavicular part. And just to summarize, do you know what are the branches coming from root and trunk? All these, remember these 4 branches over here. From root, we have long thoracic, that is nerve to serratus anterior, and we also have the dorsoscapular, that is nerve to rhomboids and levator scapulae. And trunk, we have suprascapular and nerve to subclavius. So these 4 branches over here, they are known as supraclavicular branches of brachial plexus, supraclavicular branches of brachial plexus. And all the remaining branches, all others, other branches coming from cord, they are known as infraclavicular branches. Okay, so remember that. Here you have given the branches of the cords as well. Mnemonic I am telling you over here, just you can read it. From lateral cord with the mnemonic LML. Okay, LML is what? Let me highlight it. LML is your, just a second, yeah, lateral pectoral, L, M musculocutaneous, and L is lateral root of median. Okay, from middle cord we have M4U. M4U is 4 times M and a U. 4 times M, you can see middle pectoral, middle cutaneous, cutaneous again, and this U is ulnar. M4U. And finally, for the posterior cord, we have different mnemonics. Here you can see the mnemonic ultra. What is ultra over here? U and L are upper lower subscapular nerve. T is thoracodorsal supplying latissimus dorsi. ULT, RA is radial and axillary nerve. And what are all these? These are all infraclavicular branches. What are these? These are infraclavicular branches of brachial plexus. Okay. So try to understand all these branches. Then you'll see the applied aspect as well as obspecific Uncas and others. So that's all for session. Else it will be quite a big session, and you might not, this will be too much for you to digest. But don't worry, keep on revising. And don't forget, if you have any doubts, any comments, please do write in the comment box. Okay, so that we can answer any of your doubts if you have. Save the comment box over here. That's all from my side. So do revise the topics that we discussed today. Basically, the breast memory region, axilla and contents, axillary artery branches, axillary vein, brachial plexus. All these are very, very highly important parts, right? Thanks for watching, and for more content, follow our social media handles. That's all from my side, Dr. Ankit Khandelwal. Thank you for being here. That's all. Bye-bye. All the best. Thank you.